people who are leaders.
Who's the greater the effect? Gives a strong opioid effect, but at a medium level,
I see a young man who a lot of who have tried.
this is a new day. This is a new day. Show up and share. To the people that are backbone.
We are the lifeguards of tomorrow. We are creating the future by predicting the future.
That the only way you can predict the future is to make it happen.
This is the vision that each one of us can help save ourselves, our family, our friends, our clients, and our patients.
Is to deal with our fellow human beings on this earth with compassion and a recognition that there by the grace of God go I.
Okay, now moving right along, our first speaker is a personal friend of mine and a colleague, although we kind of lost track of each other after we graduated. He does not look as old as I am, but we graduated together back in a different time in Newcastle when we had 750 kids in our graduating class, right? 3,000 in the building. Anyway, it is a distinct honor and a privilege that I bring Dr. Barber. He's a repeat person in our group, and he's part of our corporate board now, and he's going to tell you about medicine tomorrow. When you were here, you learned from Stephanie small tidbits on medicine-assisted treatment. That is, we now have a non-addicting medication that can be taken, naltrexone in a tablet form, implant, or time release for 30 days, which is non-addicting and prevents the drug and alcohol addict from feeling the reward of consuming alcohol. So we have even more exciting medical news. And again, isn't that part of what we're doing here? We're bringing it all together, and we're permanently burning it into discs so other people who couldn't be here will see it now, today, later, or years from now. But it is an honor and a privilege to present to you Dr. Jim Barber.
I want to thank you for having me here today. I've known Angelo for a long, long time. We went to high school together. But today we're going to talk about some things that are going to change medicine. We're going to talk about the future of medicine. You know, we have an audience here today. I'm going to ask some questions, and I want you to go along with me. How many people here have known somebody in their lifetime that have had a cardiac arrest, that had an MI, had a heart disease, that had congestive heart failure? Yeah, and everybody's raising their hands now. And how many people have known people who have had cancer and they've died or they've suffered, or we've not discovered it early enough? Or how many people know people who have become addicted, and they become addicted to opiates or to drugs, and we don't know them? We don't know this. You know, Martin Luther King once said, "I have a dream." Well, I have a dream too. I have a dream someday somebody gives a talk just like I'm doing today and they ask those same questions. Nobody raises their hand. Nobody stands up. Nobody acknowledges it. What we're talking about today is the future of medicine. We're going to talk about how medicine has now become, instead of one size fits all, how we're going to look at medicine as being personalized. It's no longer, trial and error medicine. It is about what we want to do to change medicine, change people from becoming addicted, change people from all the adversaries and all the things we see, you know, in medicines, the adverse effects that people get. People bleeding to death, people throwing clots after medicine, becoming addicted, not being able to tolerate the medicines they're taking. We're looking at how you now process medications. What I want to do today is show you something here. This is really the future of medicine. You know, some people have perfect eyesight and zero vision. This is the vision of the future, but it's not 10 years from now, it's happening today. We're going to talk about personalized medicine now. And we'll just switch to the sides right now. I'm really the chief medical officer for a company called Vista Healthcare. We're on the cutting edge of personalized medicine. We're going to talk to you today about a number of things. Talk about how medications do it. We're going to talk about transition from medications to compounded creams, where people can now take away the effects of the opioids by mouth and use them on different parts of their body that alleviate some of the pain without the side effects. We're going to talk about genetic testing like Angelina Jolie had, to be able to predict that you have cancer and be able to tell you, so you can have a heads up and say, hey, can I stop this before it occurs? And we're going to talk about all the things in medicine that are now changing. Pharma risk is the pattern we're going to use for this. It's going to tell who has adverse effects from a lot of the drugs we take. We'll give you some statistics here that'll blow your mind, that'll actually be able to look at you and say, I cannot believe those many things can happen. What is pharmacogenetics? Well, it's the genetic variations are common. You know that. That's me on the left, little short guy, could be standing next to LeBron James or, you know, Wilt Chamberlain or whatever. We are what we are because of what our parents passed down to us. You know, I have gray hair. My dad had gray hair at 30 years old. You know, I had gray hair. You know, I'm short. My mother was 4'9". These are things we see passed on from generation to generation. Pharmacogenetics is a well-established science that studies how an individual's genes affect the response to specific drugs. They make medications now, and it's supposed to be working for everybody. But as we see in a minute, we don't process them the same way because our genes are different. So we have so many different effects to the medication. All patients getting the same treatment, you'll see some people respond. Some people don't respond, and some get toxic effects from them. They can be overdosed. They can die. They can bleed to death. Plasma drug levels can vary up to 1,000-fold between patients, and variations in metabolism is determined by our genetic profile. Adverse effects are okay even though you write the prescription. The gentleman who heads our lab, Dr. Ward, out in Utah, Dr. Ward has actually testified at trials across the country where he's come in and said, listen, the doctor gave the right dose, he gave the right medication for these patients, but what we didn't know up until this time was how that patient processed the medication. He did everything correctly, but the medication was not processed because the patient's genes were not able to tell. Here's some statistics for you. Over 100,000 deaths annually in the United States due to adverse drug reactions. 2.2 million severe illnesses linked to adverse drug reactions. 1 in 20 people on chronic medications will have an adverse reaction to the medication. That's a staggering statistic when you look at it. More money was spent in this country on adverse reactions, an estimated $389 billion, than on prescription drugs themselves. And this has been continuing. Since 1994, they've been doing studies, and every year it goes up more and more and more. Adverse reactions cannot be predicted by looking at the patient. You have to look at their genes. You have to see how they're going to process these. These statistics here are now a little outdated a little bit. They said there's 700,000 ER visits a year. The latest study that came out this past year, over 2 million ER visits a year from these things. Now it's not longer the 5th leading cause of death in the United States. Adverse reactions to medications are the 4th leading cause of death in the United States. Now we think about cancer, we think about heart disease, diabetes, etc. The 4th leading cause of death are medications that people take that they shouldn't be taking. They're taking the wrong medication, the wrong dose, and they have adverse effects from them. 40% of admissions in all the elderly are due to adverse reactions. 40% of every person who goes to the hospital in the elderly is because they had a reaction to a medication. And 32 million Americans are prescribed 3 or more medications a day. And what that happens is, I don't know when to take it, it gets mixed up, I don't know what we're doing here. I take it personally. My father just passed away this past August. My dad was a foster child. His foster family would end up taking care of him. His dad would get drunk and he would beat him up. My dad in 6th grade had to quit school. He had to make money, set up pins in a bowling alley in Newcastle. At 18, he went to the war. He was a guard at the Nuremberg trials. We didn't find that out till years later. Came back, married my mom, worked at Bessemer Cement Company. When he started out, he made 87 cents an hour. And we had nothing, except with the greatest family life in the world. We knew what it was about to be loved all the time. Well, my dad was down at a retirement home here in Newcastle and was walking his dog. My dad weighed 95 pounds. He was walking his dog and a guy pushed him and he broke his hip. And we took him down to Masonic Village in Pittsburgh. And we had him down in Swickley, and it was a Masonic Village, and I looked at him and he was black and blue from head to toe. He was on Coumadin, and they could not regulate the Coumadin. So he was in the hospital, and he ended up passing away. And I said, listen, I got to test myself, because my dad was reacting this way. I wonder how it happened to me. I did my test, and what you'll see is a typical handout that we give to the doctor and the patient. The green boxes mean, hey, you're okay with this medication. Whatever goes through that gene on the left-hand side, whatever medication that is, you're good. Give the right dose, the right thing, and you're okay. The yellow, hey, back off, because this patient can have a significant injury from this, a significant adverse effect. And the red, that's a red flag saying, hey, you really better be careful. You can really give some serious effects. I got mine back, and it's not too bad, except I had 2 in the yellow zone, one of them being Coumadin. And I said, well, that makes sense. They couldn't get my dad regulated on the Coumadin, that's mine. We ended up doing my nurses. My nurses was from Chicago, married, went into, had a tough life, found out her husband was in the mob. Ended up, he abused her all the time. She was on numerous medications. We got hers back like this. She probably had 25 in the yellow or red zone and looked at these and said, oh my God, no wonder. I had AFib from this. I was in the hospital from this. I couldn't take this. I got sick to my stomach. And looked in the green zone and said, I take this, and now this one works. So what we're looking at here now is the fact that we can diagnose before we put somebody on a medication how they can handle this. To give you a sidebar, Dr. Ward has told us in the last 6 months when he's done these, doctors sending in the reports, they've started it takes about 7 days to get the response back on the report, to run the genetics on it. The doctors have started their patients on the medication before they got the report back. Had 2 patients die. When they got them back, they were in the red zone. If they waited a week, those patients may still be alive today. ADRs are not medical errors in spite of the compliance, but as we go on, we have to know more and more about what it is. 1998, U.S. hospitals, over 106,000 patients die annually, 50.1 for every 1,000 person years. 38% of those are classified as serious, are the most preventable. We can prevent 38% at least of those things from not happening anymore. If you look at the cost of hospitals, the average hospital in 1997, it cost them $5.6 million. Today, it probably cost them twice as much as that, just on drug-related errors. Another reiteration here, talking about over 100,000 injuries, and this is from genetic testing from JAMA. 59% of the drugs most commonly cited are processed by enzymes that are infected by an inherited DNA. This is a research paper from the IMS that just came out in 2013. If we could do medications more properly, we could save $213 billion a year in medication errors. This is how much we cost ourselves. It's the second leading cause of malpractice cases. We know the first is misdiagnosis. They did a study in 2006. The average hospital paid on almost 3 cases a year, cost them $9 million in litigation costs, just because of the fact that patients would sue because of this. And now we know that we're starting to be able to diagnose this before it happens. National survey, 98% of doctors said they really think this would be great for their patients. Only 10% said they had any knowledge of this. That number is inflated. When I went to medical school, they didn't do this. Now it's starting to become a norm, and a number of medical schools teaching this as part of their specialties. What we see as doctor are just the clinical reports. Okay, this is your lipid profile. This is your liver profile. This is what your numbers are. We don't know how you got those numbers. How did you metabolize those? What was the genes that metabolized those that gave us the numbers? Now we can go below the surface and get rid of trial and error prescribing. We can look at you before we put you on a medication and do a personalized approach to medicine. Getting it right is the right thing. Giving the right dose, the right dosage. The correct person with the correct dosage. This is what we're about today. Personalized prescribing will help you make informed therapeutic decisions. Patients will be more compliant if they stay on it. Many patients go off these medications. I just saw a guy on TV, just came back from Afghanistan. 16 different antipsychotropic drugs he's been on because they can't get the right one. I just gave a talk last week for Mercy Mental Health. The doctor looked at me and says, we should do this on every single patient because of the non-compliance, because of everybody who gets off of these because they don't think they work. Why should I test? Well, the FDA now has put black box warnings on it's between 100, almost 200 now. Black box warnings citing the gene and telling you if you're this type of metabolizer, you can have a problem with this. So the FDA recognizes it. Medicare recognizes it. Big universities now, Mayo Clinic, every person who comes in who gets stent therapy, every patient on an anticoagulant is tested. The same thing at Scripps Institute, Vanderbilt University. Now Cleveland Clinic is doing this. They just had some research this past week from St. Jude's Hospital talking about every child that they now put on codeine is going to be tested genetically because of this, because they've had people die from tonsillitis putting them on codeine and cough medicine and all these. They've died from this. And we'll show you some examples in the later part of this discussion that are unbelievable. University of Florida, Ohio State, now part of their medical school curriculum. The genotype has been the major unknown factor up until today. What we do is look at a CYP family. That's a cytochrome. That's what the enzymes are in the liver that process all these things. And 80% of all the drugs go through these. 75% of the population has genetic variations that bother this. That means they're making the medication, looking at you and hoping you're going to process it, but a number of people don't handle it the way it should be handled. We look at this again, 25% of all medications go through this particular enzyme, what's called the 2D6. All your beta blockers, which are your antihypertensives, all your opioids and antidepressants that we talked about here today, they all pass through this. 70% of people are normal metabolizers. They're going to handle it. 30% of people, everybody who's taking an opioid, everybody who's taking an antidepressant, 30% of them are not going to handle that the way it's made. So what's going to end up happening? They're going to have side effects. It's not going to work for them. They become addicted or they have toxic side effects. Wouldn't it be nice to know before we do this how they stand? This will break down for you. Poor metabolizers, this is all you need to know with this. Poor metabolizers are people who take the medication and they don't metabolize it. They only get 28% of the efficacy of that medication. So if they're on a pain med, what do? They take 2. They take 3. They take 4 pain meds to get to the dose to relieve the pain. If it doesn't, they become addicted to these. Your intermediate metabolizers get 72% of that. They don't get the full dosage. If you're looking at a poor metabolizer and he's on a cardiac medicine, what's going to happen? You put him on a medicine, an anticoagulant, so he doesn't throw another blood clot, doesn't have a stroke. If he can't metabolize it, you're just waiting, hoping it's going to work. He throws another clot and he dies. These are things that we can now predict. The last 2 involve normal metabolizers where they have both normal alleles, and the bottom one is what we call the rapid or ultra-rapid metabolizers. They get the medicine so fast that it hits them right on top of the head, and they can have toxicity right out of the gate. They can have respiratory depression. They can die from doing these things. Let's look at some of the panels now, just break it down and show you what we do. The psychiatric panel. This is what I just presented to Pittsburgh Mental Health last week, and what it talked about was 25% of adults in America have some diagnosable mental disorder, whether it's depression, anxiety, etc. 25% of us. 27 million Americans are currently taking antidepressants. 50% of those patients fail to receive remission. And the reason they don't is because we have them on the wrong medication. We have them on the wrong dose. We don't know what they're taking. Now we do. We can predict what they can take. 40% quit and say, man, this stuff doesn't work, doc. I'm getting out of here, man. I'm not taking this crap anymore. I'm spending all this money on these co-pays and it's not working. 40% of them quit after 30 days, and 10% have adverse effects. And you can see poor metabolizers only require 50% of the dose, ultra-rapid 230% of the dose. That's what they get. These are a whole variety of things. You know, some of the doctors are here now understand all the things we're talking about here and we're testing in this panel. The antidepressants, the antipsychotics, the stimulants, all these things now can be tested before you're on it. This will give a breakdown of the number of panels that are available down to a patient. The basic panel, if you just want to look at one thing. You can look at geriatrics, and we'll talk about geriatric medicine and the psychiatric and the pain, the cardiac and extended. We tell people, or we tell a doctor, if you're going to order a panel, they'll only pay for a gene one time. And as you can see, a lot of these medications go through the same gene. So if you do a basic panel and you don't do a cardio or don't do a pain or psychiatric, years from now you may be on those medications. You can't test for it again. You're only allowed to be able to test for it once by your insurance or Medicare. So your genes are never going to change. It gives you a profile for the rest of your life. What we actually do is give the patient a card and says, hey, for the rest of your life, don't take Coumadin, don't take Plavix, don't take Felding. Know these things beforehand. So if your doctor dies, he moves out of the state, you're on vacation sometime, you need surgery, You're going to tell your doctor, hey, don't put me on this medication after you do my heart surgery. I can die from this medication. I can have a bleeding incident. Patients are treated for depression. They frequently take pain meds, and we know these. It's a combination of those things. They become what we call inducers. One augments the effect of the other. Or if they have poor metabolizers, they both decrease the effect of each other. The next thing that's going to be studied in personalized medicine is how these interact, what you're eating, antifungals, antibacterials, all those things, antimicrobials, they all act on the same gene and can make whatever we're trying to make good or make it bad. There's an epidemic of pain in this country. 116 million people have some form of pain in this country, over greater than 1.5 billion worldwide. Only 58% of people who take prescription pain medications get any relief. That means we write over 300 million prescriptions for Vicodin in this country every year. 300 million, and only 58% of them are getting relief. Only 42% get relief of medications over the counter. The costs are staggering when you look about work release, how much money they lost from work, etc. 30 million painful surgeries post-operatively, and only 50% post-op patients say they got any pain relief from doing this. The metabolism of codeine varies by races and ethnicities. We have to know that. Everybody's going to handle it differently. We know some ethnicities are more prone to certain type of diseases. They also handle medications differently. 7% of Caucasians are poor metabolizers, and only 1 to 2% of Asians. But look at the ultra-rapid metabolizers. The North Africans, 29% are ultra-rapid metabolizers. That means they're going to, 29% of North Africans can take this medication and get hit all at once with it, which can cause some serious toxic side effects. The incidence of unintentional preventable deaths, and we've talked about this all day today, is off the scale. 43% of all drug-related deaths in the United States are due to pain relief. We now know that there are twice as many people who die from opioid overdoses, from Vicodin and Percocet, than from cocaine and heroin combined. That's how bad a problem it is in this country. The objective then is to look at these studies. This was done by Medco and a number of the JAMA studies. 54% of these patients were normal metabolizers. Extensive means normal. 41% were intermediate and 5% were poor. That means 46% of people who take anything that goes through this gene are not going to handle it correctly. And you see 80% of all these adverse effects were passed through this gene if you have an abnormality. It's a financial burden to the workplaces. $635 billion a year, $300 billion in incremental health care, $335 billion due to lost productivity. And costs from just pain relief alone cost our country $72.5 billion. These are black box warning on codeine. This is an interesting story. They put a black box warning on there. This was a woman who had a baby, okay? And she was given codeine post-operatively. 30% of women are given codeine post-operatively for pain, whether they have a C-section or not. They're given codeine. This lady was an ultra-rapid metabolizer. She was taking 30 milligrams of codeine. She was getting side effects. She was getting tired, somnolent, constipated. She cut the dose in half to 15. The baby was a normal metabolizer. The baby was breastfeeding. It got 40 times the lethal dose from breastfeeding because she broke it down so quickly that the baby got it whacked right upside the head. The baby died at 13 days from breastfeeding. They now recommend any woman who's going to have who's on codeine that she and the baby be tested for this because they are at great risk. And they put a black box warning citing this, citing the story here, and putting it on codeine right now to be able to do this, telling them this. This is what a problem we can use. These are things we can help prevent. The same thing with OxyContin. They're talking and they cite the gene. Believe me, the FDA is not going to do anything unless they believe that. They're going to cite the gene and cite the metabolism and talk about how you can become addicted to this, how you can have immunity from this. These are things that we can say. The psychiatric panel will test for everything. You'll see Wellbutrin and methadone and naltrexone. All these things are tested on this panel. It is a complete panel of antidepressants, anti-addictives, all these things that we can help the patient understand where they're coming from. This will show you a typical readout. What the doctor will see is a green box, and it'll tell him, go ahead and give the dose. This is good. The yellow will tell him, hey, doc, a little bit cautious with this. Decrease the dose, or you may want to change the medication. And the red will say, you better really be careful with this medication. And you can see from this patient alone the number of red boxes it had. This is one patient we had, the number of red boxes or yellow boxes that it had. Those are ones you want to back off from because you have serious doubt of having serious chance of getting problems with these patients. We'll give the literature to the doctor. We'll tell about the genes involved. It'll show all the results from these and give a total breakdown on the dosage requirements and everything else that doctor will need to know to help prescribe better for that patient. This will show you breaking down again. This is psychiatric panel. This is what we actually give the patient. It's a little card for the rest of his life. It'll show the doctor no matter where he is. These are the genes. These are the ones you have to watch out for. This will never change. This will be developing into an app on your phone that we're going to have that you can actually swipe and tell somebody. So you go someplace, you have to have a stent placed in. Doc, don't do that. You can kill me. Other panels are now available too. Cardiac panel. This country is loaded with cardiac problems. You know, when you look at some of the cardiac problems right now, and we can talk about some of those, but we start people on Plavix. 2 million people a year are placed on Plavix in this country. 20% of those are admitted to the hospital within the first 30 to 60 days because of problems. Patients on Coumadin, there are 40 million scripts a year written for Coumadin in this country. Of that number, there are 87,000 bleeding events, 17,000 strokes, 43,000 ER visits, and over 10,000 deaths due to the fact that we are putting a patient on this medication. If they are a poor metabolizer, we're not thinning out their blood. They threw a blood clot, they can throw another one. They're 3.5 to 5 times more at risk to do that. If they're an ultra-rapid metabolizer, they can bleed to death. And these are the problems they do. There have been studies done on pharmacogenetic testing that showed us now that if you test a patient preoperative, these were done at Mayo Clinic, you reduce the hospitalizations overall by 31% of everybody who's placed on a blood thinner in this country. The other things we test for, beyond testing for all these, factor 2 and factor 5. These are the leading causes of throwing clots in your body. Interesting thing with factor 5. One of the girls in my office, her daughter dated a kid, 21 years old. He was homozygous, which means he had 2 bad genes for this. If you're heterozygous, you have about a 3.5-fold, 1 to 3.5, 5 times fold of throwing a clot. If you're homozygous, you have up to 140 to 150-fold risk of throwing a clot. She dated a kid at 21 years old, homozygous for factor 5. He died. He threw a clot and died. This past Christmas, we get the Parade magazine and the Pittsburgh paper on Sunday. I'm looking at it and reading. It says, hey, if you have family coming home, talk to them about your genetics, because that can influence how you're going to be, what's going to happen to you the rest of your life. And there was a story in there about a lady talking about her dad just died from factor 5. They never knew. The guy never had any symptoms. He died from this. What ended up happening, she said, now we're going to test our entire family. MTHFR, that looks like a bad word right there, but all it is measures homocysteine. Homocysteine is inflammation of the blood vessels. This can cause methotrexate toxicity. It can cause cerebral vascular incidents, stroke. It can cause a number of things. I'll go down and I give a talk down in Knoxville, Tennessee, for about 30 doctors down there. And we're talking about this, and the lady who invited me down stands up and she said in 1985, she had a stroke. And for the next 20 years, she had TIA after TIA, 3 surgeries, 6 admissions to the hospital. She was on numerous medications, lumbar punctures, etc. After 20-some years, she finally goes and gets tested. They test her for MTHFR and said, you have MTHFR, you should be on this. She said, 20-some years of my life were wasted. If I'd have known this 20 years ago, how much money would I have saved? How much aggravation? How much heartbreak would I have saved to myself and my family knowing this? This is what we can tell somebody before they go on a medication. We can look at these other factors and say, this is what you're going to do. We now test for statin drugs. We can look at if you're on a different type of statin drug that causes what we call myopathy. People get pain in their muscles. Rhabdomyolysis, which is kidney shutdown. We can predict that by genetics and looking at this. We can look at diabetic drugs and say, hey, these are the ones that will work for you. These are the ones that don't. These are a number of panels that we can offer today. And you can see here on the cardiac panel, we will test for a number of medications. Both, they'll get the complete panel we talked about with the psychiatrics, the anti-addictives, and the analgesics, but also the anti-diabetics and the different types of opioids and everything else and the NSAIDs that will affect what we're talking about in the cardiac panel. Geriatrics, this country is becoming old. If you look at these numbers now, 65% of the population now is 65 years old, is 13% of our population. They consume 40% of the drugs. My dad was probably on 12 or 13 of these at one time in his life. And you look at these, 35% of these have over-the-counter drugs. I mean, 35% of those. Seniors will make up 19% of the population by 2013. That's a 6% increase that we're going to have in the next 16 years. That is an amazing increase in geriatrics. 77% of seniors between the ages of 65 and 79 have one form of chronic disease, and it rises to 85% of those over the age of 80. Elderly patients, they can't break it down. Now, if they're a poor metabolizer, their liver functioning is not as good as they were when they were young, they're going to be even worse. So we have to take this into account with the patients. 90% of individuals over 65 take one medication per week. 40% use 5 or more, and 12% of them take 10 or more medications. That leads to confusion, it leads to inducement and inhibition of the medications we're talking about, and it leads to some serious side effects. Seniors are involved in 36% of all the ADRs. Mental disorders in elderly people, it's a silent epidemic. Alzheimer and memory diseases we're seeing. In the future, we will have tests to be able to look at these diseases, Alzheimer's, cancer, etc. Look at the gene and say, okay, you have a gene for Alzheimer's, you have a gene for prostate cancer, you have a gene for this. They will develop nanotechnology that will look at that gene and it will shut the gene down before it can mutate. So we look at you when you're 20 years old or 10 years old and say, you have this gene, we're going to give you this medication because you have a 70% chance of getting cancer, breast cancer. We're going to stop that gene in its tracks so it can never mutate, so you never get that disease. That's where medications and that's where science is going today. Suicide rate in the elderly is greater than 75%, over 75 years old is the highest, and 1 in 5, 65 and older, have some type of mental disorder. So we test these patients so we can help prevent strokes that are causing cerebral vascular accidents, that can cause dementia, that can do this. We can help manage their mood and behavior problems. 26% of all nursing home residents are given antipsychotic medications. Whether they're working or not, we don't know. We could put these people, and laying them out all day and they don't even know where they are because we're giving them the wrong medication or the wrong dose. We should test these patients so they can live as full a life as they can possibly live. This will show you what our geriatric panel will do. It'll look at a number of these medications, combine the antidepressants and a bunch of the opioids that actually can work together to hinder them. Once again, that geriatric panel will show these things we talked about before with factor 2 and factor 5. This is the basic panel. Some doctors may say, I only want to order something. I'm a cardiologist. All I want is this panel with this, or all I want is a primary care and doing this. And you can order these, and it'll give you a good breakdown of it. Or you can use the extended panel. What I suggest to the doctors is do the extended panel. It'll give these patients the rest of their life, their pro forma. What you don't want to do is short them out. If you only test for a basic panel, you can never go back and test the opioids or everything else that went through this same gene. If it wasn't tested once, you can't test it again. This will show you right now. This is what this script does, the pharma risk compared to everything else in the marketplace. And you can see it's the most extensive panel in the marketplace today compared to all the other big labs that are now doing this across the country. Dr. Ward, who handled this, actually did work on the Human Genome Project. He's been doing this since 1994, and he was involved in a number of these. They actually did all the research and all the studies and all the testing for Ancestry.com. So for millions of people, they've looked at your genetics and see how they process. Once again, a breakdown of how the panels are extended there. All you have to do is understand how it's important. The doctor will look at him. He'll check off what panel he wants. He'll look at the disease and run the extended panel. He will put the evidence and do it. He will say, this is the reason I'm ordering this, so that insurance pays for this, Medicare pays for this, and 90-some% of insurance companies will pay for this, testing for the patient, and they'll get a wallet card after they're done. Why should we do this? As a reiteration, it reduces drug reactions, adverse effects, it personalizes treatment, it minimizes liabilities for hospitals, for doctors, for everybody else. It takes away a number of costs, and it lowers those costs, and it takes away trial and error medicine. Patient, it's simple. It's a buccal swab. You do a swab inside your mouth. It stands up, you send it in, and it comes back within 7 days and telling you with your genetic profile. It's personalized and it's proactive. It's looking at you before you have something done. We're going to go transgress a little bit. We're going to go in a little different form now. After you have surgery, we put patients on medications, opioids. But we don't want to keep them on that forever. That's how they get addicted. So what we're seeing now is the use of personalized medicine in the form of transdermal creams, personalized things that patients and doctors can use. So you can take away some of the side effects that you get with the opioids, some of the things you're taking by mouth, and deliver the medication to where you want it done. This is another step in personalized medicine. It limits the use of oral medications, and it's directly specific at that areas. It's a patient-centered approach. Pharmacists are available to consult with these doctors, committed to the highest quality with this. Why should we do these? Well, a lot of patients who take stuff by mouth, whether it be aspirin, etc., they get upset stomach, they get constipated, they get all the side effects of this, drowsiness and dizziness. They can have all these type of things that they're having. A lot of people don't like taking pills all day. They don't like doing it, and you get the systemic effects of becoming addicted to these medications. You can't do this forever. So what we can do is really go to another form of this. Put them on the pain medications for a little bit, test them beforehand to see what works for them, and then perhaps use some of these. These combine various drugs that are pharmacized. They actually go to a pharmacy. The doctor checks off the medications you want, so it's personalized for you. And they improve pain relief and the quality of life and the compliance because it makes it simple to be able to do these. There's a number of studies that have been done on these, research studies and papers done. This particular study was from Johns Hopkins and out of MD Anderson Hospital, which happened to be one of the hospitals I trained at down in Houston, Texas. And what it talks about here is that 83% of people who took transdermal cream said they got some form of relief, an average of at least 57 to 60% relief of their pain, enough that 36 to 40% of those patients stopped taking their opioid medications. This is what you can do to help the patient out. The delivery system is important. I'm a plastic surgeon, I know that. A lot of the skincare creams we use, people think they work, a lot of them don't because they can't get through the top layer of the skin. They can't go to where you want them to go, so they don't work. It has to go through all the layers of skin to be able to do this. What this does is it's put a different base, a different delivery system of this. You'll see when you take something by mouth, you get a high percentage of it. Only 5 to 15% of these goes into your system, so you're not going to get the systemic side effects. So lower doses and increased compliance. It's what we call a lipoderm effect. The lipoderm here is both what we call hydrophilic and hydrophobic. It'll pass through the top layer of skin. That's called the stratum corneum. That's your epidermis. That's dead skin. That's what you slough all the time. Ring around a collar, the bathtub ring. That's what you slough off. You have to get through that dead layer of skin to get underneath. This formulation is the only one in the business that allows it to be able to pass through all layers of skin, to go down to the nerves, go down to the muscle, to take away the pain. We have what we call, there's pentophyllin in here. This actually blocks inflammation. The reason that people see pain, whether it be bursitis or tendinitis or plantar fasciitis, all those things is they have inflammation to those areas. That's why you get steroid shots to help take away the inflammation. Included in this is an anti-inflammatory. It decreases the inflammation at those points. Basically, you can see some of the other things in there. They actually take away a lot of the causes of inflammation. They block this. That decreases the pain you're having because you're stopping it in its shoes. Taking the NSAIDs, the Aleve, all these type of things, that's what they do, but you're getting the side effects. This will show you the absorption pattern of each one of these medications. And the nice thing about this is you can put 4 to 6 medications in this at one time. It's not like taking 4 pills. You can put things like baclofen, which affects muscle contraction, or ketamine, which is a type of analgesic and anesthetic. You can mix all of these in one cream that you can take instead of having to take 4 medications at one time. This is a study that's done by PCCA, and it shows that the lipoderm is the only proven base to deliver up to 4 medications at one time with this. These will show you the different types of medications that are in there, the different types of pains it can take about. Bupivacaine for the anesthetic effect, the neuropathic, which is the nerve pain, the muscle relaxants. Each one of these can be combined in a medication, in a formulation that can be applied directly to the site of pain. The other thing that I deal with a lot, and we'll talk about this, and this will be very short, is on scars. Everybody comes into a plastic surgeon, am I going to have a scar? Well, I'm going to have to do surgery on you. If I cut you, you're going to have a scar. I make the scars, God heals them. But what we try to do is give the best results of these. And a lot of people don't like scar therapies. What we're doing now is they now have personalized stuff for patients who have new scars and old scars. We've seen stuff, we've done stuff in our offices, we've sold. This is a breakthrough on this. When you get cut, if you have a surgery, you have a trauma, the body wants to shut off that defect, the cut. It slams all the collagen in there. The collagen is the stuff that heals the wound. It slams it in there. And they're all haphazard and tangled. That's what gives strength to the wound. So you have what we called before, a pro-inflammatory response. The body says, we're injured, let's put all these in here. We need inflammation to stick this together so it doesn't open up, so we're not exposed to anything. After a while, when that inflammation quells down, is when the scar heals. What some people see, you see African Americans who have, keloids or hypertrophic scars, they overproduce that collagen. We can't stop it, we can't break it down. This is what this does. It'll actually stop the inflammation, it'll stop the scarring process and reverse that process by using a number of medications. This will show you a result. This is 8 days after this little baby had a burn, putting this on the baby. 8 days after doing this, because now you can compound medications that will directly affect this area. This is a silicone. We know silicone is great for healing. Other things, when patients have hypertrophic scars or keloids, we inject a steroid. What that does is it potentiates what we call collagenase. Collagen makes a scar, collagenase breaks down a scar. This makes collagenase increase its efficacy so it breaks down a scar. These things you'll see here will have a silicone base, and we'll see these. You can use these at any time. There's a hypertrophic scar or keloid. It'll blend things with these, active ingredients in these. So the scar therapy was actually studied now by light therapy. 100% of patients had improvement, up to 72 to 74% in the depth of the scar, the thickness of the scar, and the color of the scar. UTIB, you can view these. These are a number of ingredients you can see in these scar things. Collagenase, which we know can basically break down the scar. Hyaluronidase, which breaks down hyaluronic acid, that can help form the fibroblasts which make the scar. And we've talked about a steroid in there with fluticasone and doing these, as well as being able to look at some of the anti-inflammatory. So we cover all the bases in both pain and scar relief to the patient. What I tell a doctor is, if there's any doctors here, if you have a scar and you have surgery, if it's on the face, we do the stitches in 5 to 7 days. On the body, 10 to 14 days. Wait at least 10 days to 2 weeks after the stitches come out to start this, because you don't want to shut down that inflammatory process too soon, otherwise the scar won't stick together. It'll break down. So you want to wait till it's solid and then start affecting the scar. Once again, this Medicare and Medicaid does not cover this, but a number of the insurance, about 60% of them do. Once again, the doctor will prescribe what he wants for that particular patient in doing these. Once it's approved, the patient is called and said, hey, you're approved for this, this is what it is. They talk about their co-pays and they help the patient out in paying this. These will show you what the typical pads will look like. The doctor just checks off the code for what it is, what the coding is for that particular malady that the patient may have, what the pain was from, diabetic pain, sciatica, is it from plantar fasciitis, is it from epicondylitis, is it from any of the things, muscle pain, fibromyalgia, all the things that he can check off, and the same thing with the scar creams. And the combo pad basically works for a lot of doctors because they can do 2 at one time. Toll-free number doctor can call. There's also things online the patient can talk about. The last thing we're going to talk about in compounded creams is pretty cool. This just came to our attention. They can now compound creams for patients who have allergies, patients who have rhinitis, who have chronic sinus infections. They can now do this for the same thing for these things and deliver the medications where they need to go. This is the NasoNeb. It's a patented device that is now available. This is designed for aerosol medication. A lot of people out there think, well, I'm using something right now. But let me tell you what the difference of this is, and you'll see some studies here. Topical medications have to be delivered to the nose. When we take some of these other things in there, the particles are so small, they go to the lungs. So you're not treating the sinus trouble, the asthma. It's going to the lungs. Over time, that can cause some problems in the lungs. You cough immediately, it can hurt you. The other thing that it does is it doesn't really affect all the nasal sinuses, the frontal sinus, the sphenoid, the ethmoid. This is a drug that can basically deliver this. You see there, no more than 3% of some of the drugs delivered in some of those other systems ever go to the nose. So you're just wasting your money and wasting your time. This will show you, it's just an outline of what the nose looks like, looking at the different sinuses we need to do. Different types of delivery systems. The pulmonary nebulizers deliver only 3% to the nasal passages. 3% of that medication is going where you need it. The rest is going to your lungs. The powered irrigators, no more than 10% go there. So you're not getting an effect with those. This nebulizer, in order to deliver, has to have a micron size of that particle greater than 10 to 15 microns. And you can see the other things that are out there. Very small particles, very little delivered where we need it. What you see here is why the particle size matters, because we talked about it. If it's small, it's going to go right through. It has to be big enough to stay in the nose. What this particular cycle does, the microns average 23.3 microns, much greater than the 15. And basically what you'll see here, it's 99% of that are greater than 10 microns. Now, what supporting airflows does, it directs the particles to the nose, as we talked about, and it delivers sufficient airflow that you can get it where you need it. Large unmet need. 16 to 25 million people in the United States suffer from this right now. The NasoNeb advantage is demonstrated, it's peer review. This is the only thing that has research studies actually done on this to show that this is the only one that works. It delivers it in 1 to 2 minutes to the nose. A lot of studies done. They cite these and observational things on these. It'll show you a bibliography on those. Some of the things the doctor can send are a number of these: antibiotics, steroids, antifungals, montelukast, which is allergies, singular, or those type of things for all these problems with rhinitis, with nasal polyps, with recalcitrant things, and anosmia. Otolaryngologists, ENT, primary surgery doctors, all these things can do these. Large unmet need out there, multifactorial disease. The last thing we're going to talk about here is the thing Angelina Jolie brought to attention. Prevent test, her BRCA1, BRCA2. Vista Healthcare now has a study that will actually look at you and predetermine for 8 different cancers. It'll tell you whether you're high gene potential for colorectal, breast, ovarian, endometrial, prostate, pancreatic, gastric, and melanoma. And what's good about that? If you know it up front, you can get a colonoscopy if you know you have a high potential. We're talking now, people with BRCA1, BRCA2, like Angelina Jolie had, have a 70 to 80% chance of getting breast cancer. They also have a high risk of ovarian cancer, and they recommend them at 35 to 40 years old, take your ovaries out after you have your babies. These are all the genes that are tested there. Once again, you just fill out the request form, send it in. Multiple insurance companies pay for these. If they're negative tests, they'll be returned within 9 days. If they're positive, extra 5 to 7 days so they can retest these, and there'll be genetic counseling. Once again, just a buccal swab will do this. Informed DNA is where the future is going. Counseling is informed on every aspect of what we're doing here and doing this. All they'll do is fill out the genetic counseling referral form. There are a number of great things we're seeing in personalized medicine right now, and in closing, there's just a couple of things I want to say. Success is getting what you want. Happiness is wanting what you get. You know, it's not about being the best. It's about you being better than you were yesterday. And that's what life's important about. You know, it's, if you hate starting over, then stop quitting. You know, limits are the starting point to greatness. You know, it's for those who don't dream. It's only the starting point. If somebody tells you you have a limit, you can transcend that. You know, and as you all know, yesterday was history, tomorrow is a mystery, and today is a gift. That's why they call it the present. Remember, there's only one way, and we end this every time talking about this, to predict the future of what your life or anything might be, and that's to go out and create it. And that's what we're doing with personalized medicine today, creating a future today. Thank you for having me here today.
Thank you, Doc. You will get our normal certificate, baseball hat, etc. Nice. Thank you.